My name is Michael Kerr. This is a talk on traumatic cardiac arrest. The opening thing to remember that a traumatic cardiac arrest is not a medical arrest. They're completely different arrests and should be approached differently. Medical arrests are generally a disease of the older population and generally are related to either a cardiac or a neurological focus. Traumatic arrests are generally of a different etiology. The priorities of a medical arrest are immediate CPR at a rate of 32 in an adult.
Check patient.
The reasons for providing CPR is to provide effective coronary artery perfusion until effective definitive treatment can be provided. The emphasis is on early, uninterrupted, good quality CPR to restore blood flow and coronary perfusion and generate an end tidal CO2 greater than 10. Once CPR is established, early defibrillation to reverse shockable rhythm. Once we have got post-defibrillation, we then move on to recycling through CPR and defibrillation before moving on to advanced drugs such as adrenaline and amiodarone. Note, advanced airway is not initial priority. Basic airways are adjunct. Generally no intubation until at least the later stage of resuscitations after 6 to 10 minutes. Okay, so let's examine traumatic cardiac arrest. In traumatic cardiac arrest, the emphasis is on reversible causes. So a way to think of this is either airway, breathing or circulation, or another mnemonic we can use is HOTT, hypovolemia. People die from traumatic cardiac arrest primarily because they bleed out. That is something we need to address early. Another reason they die is because of lack of oxygenation. We can fix this by doing intubation. Intubation has shown to have a survival benefit and prolong the time that patients can become viable in arrests. Tension pneumothoraxis. This must be discounted early. You can do this by decompressing the chest with either needle or, in more advanced cases, finger thoracostomy. Tamponade. Tamponade is referring to pericardial tamponade. This can be examined with an ultrasound as well to be ruled out. Okay, let's examine traumatic cardiac arrest. In traumatic cardiac arrest, we're concentrating on reversible causes. It's a very simple algorithm that we use: airway, breathing, circulation. Airway. We need to provide early advanced airway with this patient. This is generally done by intubation to address any issues in regards to oxygenation and hypoxia. Breathing, bilateral chest decompression. Traumatic cardiac arrests generally need to have their chest decompressed to rule out that as the cause of obstructive shock and for causing the arrest. C, circulation, very important. Number one cause of people dying from traumatic cardiac arrest is hypovolemia. We fluid load these patients aggressively and we provide aggressive hemorrhage control. Hemorrhage control is provided with a pelvic binder, tourniquets, direct pressure and pull fractures to length. These are our priorities in a traumatic cardiac arrest. You will notice there's nowhere in there in the initial stages for defibrillation. They don't present in a shockable rhythm generally, they're in PA, and there's nowhere in there that I can see for CPR or adrenaline. They're not treatment. Okay, a major point of difference in the traumatic cardiac arrest is CPR. Gary, I'll get you to stop doing CPR on this patient to traumatic cardiac arrest. We don't generally do compressions to traumatic cardiac arrest. Is not a priority. There's other life-saving interventions, airway, breathing, circulation, which we need to concentrate on. Plus also cardiac compressions in a normally only present 10 to 30% of normal cardiac point with normal volemia. So generally in a cardiac arrest, that's not going to provide sufficient return of circulation to the heart to be effective. The other question that's often asked is why don't we provide adrenaline? Adrenaline is not provided because these patients are generally fluid depleted. They have no preload. Adrenaline is given to increase coronary perfusion pressure. That's not a priority in this case again. We need to do airway, breathing and circulation. We need to give this patient fill to get blood back to his veins, fix his airway and treat any obstructive shock as the treatment priorities. So we're presented with a traumatic cardiac arrest. This patient has come off their motorbike and has got a fractured pelvis and are likely bleeding out from their pelvis and they also have head or chest injuries. Generally in this situation, simultaneously actions are going on. For the sake of exercise, we'll break them down into sections. Generally the CCP will go to the head end and perform an intubation and then quickly move on to a decompression of the chest. So I'm wearing on my PP&E. The first critical intervention of the CCP is intubation. See the cords, tubes passing down through the cords. Cords in at an appropriate length of 23 centimeters for an adult. That happens. 10 mils in, bag valve mask on, and intubation. Confirm with end-tidal CO2 checks. Job done. Next skill that we'll be doing will be decompression of the chest to rule out obstructive shock. Next critical skill is decompression of the chest with an pneumocath set. Both sides will get done in a traumatic cardiac arrest. For the sake of the exercise, only one will get done. Find the midclavicular spot. Come down first rib, second rib. Find in the second rib. You swab second rib. Confirm your placement. Advance the needle. When you get a pop, advance a little bit more. Draw back. You should get rush of air. And then you feed your pneumocath off, disposing of your sharps safely in a sharps kit. Repeat the process on the other side to rule out obstructive shock. What we've achieved in that short period of time where things are going on simultaneously. We've intubated the patient, we're bagging them out and ventilate them at appropriate rate with end-tidal CO2 to confirm proper placement of the tube. We've decompressed the chest both on the right and the left and the right side to rule out as best as we can for pneumocath obstructive shock. C is now the next priority. This will generally can be done at an ACP level with direction from ICP, as it is a skill of their level. Interventions that should be done simultaneously is C for circulation. We're controlling hemorrhage. We're suspecting a pelvic fracture causing extenuation, so we need to address that. Easiest way to do that is place the binder. The binder is placed in appropriate length, so it's actually contracting the pelvis and stopping any bleeding. That can be done very quickly. Somebody then pulls any fractures to length. This is to gain anatomical alignment of fractures to help stop bleeding. Of course, if there's any external bleeding, direct pressure is applied to control that as well, and you can also use tourniquets if that is not effective. The other key intervention that needs to be done, again, is giving the patient some preload. Give him some fluids. So we aggressively treat with fluids until we get a return of ROSC. So generally this can be done by a bystander, or whatever resources you can, an ACP bystander, firemen, police officers, to squeeze the fluids in so the trained professionals can go on with the other life-saving goals. It's all a matter of using best use of resources. Future directions in paramedic care, which are currently being used in some states and aeromedical services, and will be probably a big part of the future traumatic cardiac arrest. We're progressing to finger thoracostomy by using purpose-built kits. This provides a definitive answer on whether the patient has got obstructive shock from a tension or hemopneumothorax, and we can manage that quite quickly. Blood and TXA, especially important for extenuation in the post-ROS patient, very important. The other big advance is ultrasound. Ultrasound is great. It will be able to tell us if the patient is having some sort of pericardial tamponade. It can also for pneumothorax, hemopneumothorax, and also for determining if the patient has actually got any electrical activity via sonocide, ultrasound imaging, whether there's any actual mechanical beating of the heart. On ultrasound, we basically put some gel on the xiphoid to get our views. Overhand grip coming into the Ziffy sternum like we're scooping ice cream. Coming up and we're getting a rebounding off the liver and trying to get some cardiac views on whether there's any pericardial tamponade or whether there's electrical activity of the heart. The other view you can use if that doesn't work is either your parasternal long or parasternal short view to get good views of the heart, as well as your apical views. A very useful tool and undoubtedly will be part of paramedic practice in the near future. Okay, in summary, the important points from this video exercise is to remember, traumatic cardiac arrest is not a medical arrest. They are done completely differently and have different priorities. The priorities in a traumatic cardiac arrest: reversible causes, airway by intubation, breathing by decompression of chest, either finger or needle thoracostomy, circulation. Must control any bleeding both internal and external as best we can. We do that by having a pelvic binder on early, tourniquets, direct pressure, pull fractures. We fluid load the patients to up to 2 litres until we get ROSC. If we get ROSC, then we can start thinking about blood and tranexamic acid and other things as well as that. Those are our priorities of care. I've shown you what we do individually, but it's not an individual process. It's very much like a GP tyre change. It's very much directed and things are going on simultaneously. We're trying to reverse the reversible causes quickly and assigning tasks to the appropriate people. ICPs do ICP tasks, air intubation, decompression of chest. ACP bystanders can do pelvic binders, pull fractures, and squeeze bags of fluids to get the end result.